However, we do have a number of those laws, the regulations are in place to support the digitization and innovation in the health sector, and of course standards. Data protection and privacy, very key in the health environment. We do have a data protection office. In the next, I think, panel of discussion, we'll have our data protection colleague who's going to get into the details of that data protection. Very important and very key. Without these laws and enabling environment, you'd have a challenge. Just give you an example, we work with the judiciary. They recently, like 3 years ago, implemented the electronic court case management system. I don't know if we have lawyers in here. And the lawyers came up in arms. Where is the law to support this? And so on, and they made a lot of noise. We said, but we do have Electronic Signatures Transactions Act. Those should be able to support. And of course, they were lawyers, so they went back. And of course, there are other legal instruments that helped the electronic court case management to come into play. But yes, so in terms of the environment, enabling environment, we are at par. The only challenge is implementation, enforcement actually, not even implementation, but enforcement, which we'll talk about. Next slide. I put up this slide just to give you a bit of snapshot of what we're doing as government. Digitization blueprint, we're calling it the digitization blueprint. This is not on paper, it is actually working. We want to see a smart government, and of course a smart government, we are also looking at the smart health sector in there, of course with the other sectors. We have what we are calling UG Hub in the middle there. It's a government integration platform. What that platform is doing is that it's connecting all the data or the systems in government. My developers here would be excited about that. All government systems are now connecting to each other. I'm trying to use simple words. And exchanging information across the board. That is being done through the UG Hub, that is being managed and maintained by NITA. We'll not talk about the connectivity, but at the end of the day, we want to see how can we improve on our services. We are not yet there, but those institutions that are mature enough are connecting to this platform, and they're able to access whatever government data that is required for us to be able to provide the services that we need. I just thought I would say that, and why, because some of you, the innovators in this room, if you want KYC, our insurance companies in this audience, if they are there, if you need to access the national ID, which is very key identification of persons, you can always come through NITA, and you can access that. Of course, there is a lot that needs to be done. It's not as easy as just accessing, right? But you're able to do that. The insurance companies, the banking industry is able to integrate with that, with the national ID, and even with any of the other government systems that you want to talk to for information to help us have better. Next slide. This is basically the just wanted to bring it out to emphasize, but we are using that in future, probably in the next few months or a year. We'll have one portal, what we are calling the citizen portal, where we'll have all government services there. Hopefully we'll also have some of the health innovators services on that portal, where citizens will be able to access the services. Next slide. Let us now go down to the core, where you're the expert here. Okay, what is the landscape in the health sector? What has government done around the health sector? Fiber connectivity, it's about 15% of the health institutions connected. Government institutions, about 4,800 facilities, private, I mean public, again public. And out of that, about 15 are connected to the NBI. So you can see we do have a lot of work, but the referrals across the country are all connected. All national referrals are connected to the fiber. So meaning that the systems that are there are able to be utilized and of course shared across the board. The mobile connectivity, where the telecoms are supporting us as far as health institutions are concerned, is about 80%. We have, of course, the health system that we're trying to roll out, that has been rolled out actually to most of the health centers across the board. You've heard of the DHIS, yeah. It's a common phrase in the health sector. I know you have read about it. M-Track, that is supporting the health-based, SMS-based platform. Those are some of the things that we have done or supported the health institution. Go ahead, that is infrastructure. Next slide. The policies. The health sector, interestingly, has a number of policies and strategies. The health policy, the digital health strategy, which is expiring this year. They are in the process of seeing how to upgrade it, the data protection in line with the national data protection, and so on. So the policies are in place. I just wanted to highlight specifically for those which I know you already know about. Next slide. The policies are in place. The standards have also been put in place. I know there is a lot of conversation around the standardization of our systems and technology, but we are getting there. Okay, it's not easy. We, as you're aware, which I'll talk about maybe when I go to the next slide. But yes, let me just put it out here. The standards are also in place. The interoperability standard was based on the National Interoperability Framework that is supporting government, and it's being handled by NITA. So you have some stepping stone or pillars that you can use to thrive as far as innovation in the digital health sector is concerned. Next slide. NITA's interventions really, from the health perspective, connectivity, and we plan to connect as many more sites, about 600 in the funding that we got recently. Health centers about 696. And we provided a few things within the health sector I may not get so much into at the moment. Next slide. Challenges. As always, we talk about challenges in all that we do. We can't escape them. The budget for digital health is only 5%. It shows our focus and interest in this country, but we are still lobbying to ensure the Ministry of Health, of course, is doing a good job there. Of course, we have an issue with many health systems known to us, about 64, known to NITA. There's a possibility that there are even many more out there. And within just public sector, you can imagine. And all of them not coordinated and so on. Connectivity by default, we've talked about it, is a big issue. We've talked about the digital skilling. We are talking about innovation, we're talking about digitization, but what are our people, how are our people being able to handle that and manage that? About 60%, the gap that we have in there. Next. So with all that, what is the strategy for government in the next coming years? We hope to at least connect 90% of the health center facilities across the country. Interoperability, standardization of these systems to support seamless integration. We were approached by Ministry of Health a year ago and they said, please help us. What do we do? We have too many systems. How do we ensure that we gather that information together? When we went in there, we realized that the systems run different technologies. Our developers in the room, the APIs became a problem. How do we standardize that so that we ensure that you, the innovators who are coming on board, your systems are interoperable for us to exchange data across the board? AI adoption in this country, we're in the process of coming up with an AI framework under the Ministry of ICT to support AI as a country. There are very few countries in Africa, about 5, that have policies around AI or AI-related frameworks. So, but we are getting there. Hopefully by end of this financial year, by end of next financial year, we'll have some guidelines around AI. So as innovators, please have a look out when that comes into play. The last point is very important. Partnerships with the private sector. As government, we cannot do everything on our own. It's not possible. We need the private sector, we need you. Your innovations are very key and important, so we want to find out the incentives that we can provide most of the innovators to move to a next stage. I've talked about infrastructure. We want to extend that across the country. Last mile connectivity to the rural health facilities, partnering with the Uganda Communication Commission as well. We want to go green, solar-powered internet equipment for some of these health centers. I think yesterday one of the people mentioned again around infrastructure gaps, electricity. So how can we use solar to support that? So those are the things that we are coming, that we are working on as government moving forward. Next slide. So around infrastructure, around the health systems, like I've said, we want to see how to unify the health systems within government. And we're trying to champion that interoperability framework within the many systems that are there. The electronic medical records, we want to scale it up. I know you're very familiar with that, and we want to see how to move it to all the hospitals and all the health center folds across the board. Next slide. Regulatory framework, we already are good in that area, but there are more guidelines that we need to put in place. I know we have one at national level, the data protection, but the health data protection guideline, aligning with the Data Protection Act, the digital health standards. We want to get into the public-private partnerships and do some more work with the entities so that we can improve on our digital environment. Next slide. I had written that as a conclusion, but I wanted to say something a bit different. We have established all these aggressive digital health policies and frameworks. But the challenge, which most of you have mentioned, is implementation. We have the environment, the enabling environment, but how do we implement it? I don't know how many of you have registered with the Data Protection Office as data processors. The law is in place, the regulation is in place. How many of you have? The many innovators in this room. Compliance. One of the gentlemen there has, at least there's one hand. But in Kenya, I would want to implore you that we need to comply. So it's not that government has not done anything. Government has done. Compliance is a problem. Enforcement probably on our side is the other bit, which we are working on, and we want to see how to support. The digital health strategy that is coming next from 2025 to 2030, we want to ensure that we emphasize or present some of those opportunities: connectivity, interoperability, and skilling. Those are our core as government as we move into this digital world. With that, I want to thank you and wish you a wonderful day. Thank you very much. I saw my neighbor writing so many questions, so I will need a chair or something, because she has several questions. Actually, one of them said, if my Zoom freezes, should I blame Nita or the rain? It's as far. Or if my grandmother is able to access WhatsApp, should I say Nita has performed 100%? Those are some of the questions that will come along. Thank you so much, Madam Juliana, and we need a seat for the presenter. She says she's strong for the questions. Yes. So some of the points we have taken, we have gotten the focus areas, which are basically 5. We have gotten the focus areas, which include the infrastructure. We have had that enabling environment. We have gotten capacity building, information security, automation. All that has come up. I've seen the hand up. QA session, not yet. Not yet. Then we have seen that there are strategies that are coming up, and I'll be glad to say that we have, despite the shortcomings that are there, that is limited funds, fragmentation of information, then rural connectivity and workforce gap. There are strategies which include universal connectivity. We are going AI adoption, and we are looking at the PPP, and most of us here are in those private partnerships. And one of us here actually has registered with Uganda data protection, but he said they train also. So let's also check out what is there. As we are asking for these questions, let us remember that it is a stepping stone for thriving. That's what she says. So yes, questions, where do we start? I'll go per row. Let me start from here. Not because there is my supervisor is here, but her hand was the first.
Thank you, Ms. Madam Juliana. My name is Rose. I'm co-hosting this event with Mobi Clinic. I'm from Clark International University, Vice Chancellor. 2 questions. The first is the smart education and intelligent health. Could you elaborate about those 2 things? What does the government want to see so that, entities and universities can begin to fall in line? What is the expectation there in terms of smart education? The second question is that the government is doing a lot. I'm so glad I sat in your presentation, because a lot of what you highlighted, I knew maybe about half of so far some of the guidelines the government has been developing. However, Madam Juliana, what effort is being made for dissemination? When you talk about interoperability, government and private entities within healthcare, the use of electronic medical records is now, taken root. Many private organizations do have these softwares. However, how is that data being integrated into the national health system to inform decisions and policy? Thank you.
Thank you. We shall have 5 questions. 5 people, not 5 questions. We have 3 questions, but 5 people. Then we. This row.
Thank you, Julian. Mine is not a question, actually. I rarely ask questions when it comes to government, because normally the answers are not immediate. But one thing I must say, NITA has done great work. But when you were presenting, actually, you mentioned something that you visited most of those hospitals and most of the systems, actually the Ministry of Health, and the systems were not interoperable. Then that makes me wonder whether government institutions really belong to government. Because if Ministry of ICT or NITA is not knowing what is happening in Ministry of Health, money is spent there, you buy systems, by the time you are visiting, you find that you have to discard them, and then you do new things. Then two, if you don't do the small things like digitizing the passports, digitizing the national IDs, I don't think all that beautiful work you are doing there is going to benefit us. One simple example, last year I traveled with my son. Surprisingly, his passport was scanned, and me, I had to put what? My fingers to be scanned. And this passport I renewed it around 2023. But according to the policies you've presented, they have been there since 2021, since 2020. So if we still have analog IDs, passports, name it, and it's one of the things we talked about here yesterday, that today you go to Mulago, they ask you where do you stay, what, those names and so on. And yet, NITA is busy doing the work. Then lastly, these cables have been laid, it's now I think more than 10 years. But I'm surprised that still we've only covered 70 districts. And today, as you are moving within Kampala or somewhere, you find there is a cable cut. As if the constructors didn't know that here there is a cable passing. So if we don't address those small issues, we'll keep moving in circles and we'll never achieve that goal. Thank you.
Thank you, Madam Julian, and everyone. By name, I am Albert Mario Boapus. I work as IT security and data protection manager, Mengo Hospital. So my question goes to Madam. I have just seen that NITA has a strategy for strengthening healthcare cybersecurity. As a cybersecurity personnel in healthcare industry, I would really want to understand what is the national standard for the implementation of cybersecurity to the healthcare systems, in that we are so much interacting, or each hospital has different systems in silos. Then we also interact with a lot of third parties as concerns the APIs for different services. What would be the standard or a checklist that all these facilities must adapt to strengthen the cybersecurity in the healthcare? Thank you.
Thank you so much, Madam Juliana, for a wonderful and informative presentation. My name is Mpato Wakage. I am a digital health regulation consultant across the continent. My question is born out of some embarrassment that I faced in my professional duties. You've said that we have interoperability standards. Ordinarily, I was supporting a partner who was doing work here on Uganda's readiness for digital health innovations and regulation, and I looked at the NITAU website to try and find out whether we have interoperability standards. I have just checked again. There's nothing published there, so perhaps my comment builds off of what Professor Rose has said. You have all this information, a wealth of it. There were a number of statistics that you showed us, and I think you saw people scrambling to take photographs because there's nowhere else they're going to find it. It's not on the websites. So after advising this client that we don't have interoperability standards, I was in a dissemination workshop, and then we had invited somebody from NITAU, and then we were advised that you have them. So the challenge is you have them, we don't. People in the sector, people that are interested in the sector don't have them. So kindly take very seriously the comments towards publishing this information, even towards audiences that are already active in this space. But also secondly, I would like to hear your comments on what exactly the challenge, especially within interoperability, is. A previous speaker has already expressed the same frustration. We're not short of benchmarks. Right now, I can use a Centenary Bank ATM in an ABSA ATM machine, and I'll get the cash. That's interoperability. Their systems are talking. I can send mobile money from my MTN to Airtel, but Mulago National Referral Hospital cannot speak to Rutabika National Referral Hospital. So that's really, I don't want to use the word embarrassing, but you've said the telcos, and you have a regulatory role in the telcos as well, because you're the national IT authority. So if the telcos are doing it, they're speaking to each other. The banks are doing it, and they're using systems, ICT systems, which you ostensibly regulate. Why can't Mulago speak to Rutabika? Why can't a health center 4 speak to a national referral? Why can't Case Hospital speak to Mulago National Referral Hospital? Because again, we are also going to have a challenge in seamless data transfer between the private and the public.
Thank you. I saw people when you said MTN and Airtel, so that is interoperability. Then you said, thank you, we have understood. Some of us have understood. Kindly come forward for the 5th question. We shall come to that row. Then we finish this. It's the caller. Then we go to the other caller.
Thank you very much, Madam, for the good presentation. I want to take on from what the consultant is saying. I'm called Professor John Charles Okiria. I work with Clark International University. I'm a regulator with the Allied Professionals Council, the chief regulator. Now, from what the consultant is saying, I have just a living example, and it's good that I came here today. I cannot currently pick money from any of my bank accounts because my ID card is expiring on 28th June. Let me not say the year, because that one is private. That one I can keep changing depending on the job requirements. I cannot pick money from the bank, from an agent. And the reason, when you put your card, it will tell you an error. So I went to Centenary. Centenary said, you know what? Your national identity card is expiring soon. So it has been put on error. I went to Stanbic, same thing. Standard Chartered, same thing. Now your identity card has now become an encumbrance to my business. I can't pick the money. So, manager, before you leave here, you better give me a solution. Because this is serious, I submit.
We need the money. We need to access the money. Then I'll come to this column. You want to handle that? Then. So let me. Yeah, we do 3 progress. Then we finish.
Thank you, Madam Julian, for a nice presentation. Edwin Muller with Village Reach. I'm from Kenya. So maybe to start with a kind of like a positive experience, and then my question. So last year, when I was picking my son from a football game, I was stopped by Uganda traffic police. And he stopped me, then he put my, the driver's, the registration in his mobile phone. Then he came to me, Muzei, how are you? How are you today? Your insurance has expired. I was not even aware my insurance has expired. I'm in and out of the country. And he said, so I have to fine you for that. So he does something on his phone, goes to the motorbike, comes out with a printout of a fine. And I'm smiling at this time because I have an IT background. Then he asked me, why are you smiling? I said, I'm very impressed that you are picking up my details. You've actually given me a printout on the spot, which I can pay a fine. So that for me was a positive experience because I could see digitalization happening on the spot. So that was nice, even if I had to pay a fine. I enjoyed that experience because it was digitized. But to my question, 64 uncoordinated digital health systems. What is NITA doing to coordinate those, or also to reduce on possible duplication from these 64 systems? We don't want to stifle innovation, but that number of uncoordinated digital systems, possibly some amount of duplication, what is NITA's role in handling that?
Second last, then we have the last one.
Thank you so much. Nelson Mandela is my name. I work with a company I'm the CEO of a company called Stanfield Commodities Exchange Group. We are into health as well, and I'm also a medical forensic professional. I want to ask a question related to what you talked about regarding the IT integration. So I also face similar issue regarding the national ID. So my question was like, is it possible for NIRA to integrate, because these people already have the database. If you go to NIRA, they already have our national ID database. So instead of going to the bank with a physical ID, is it possible for NIRA to work with NITA to integrate all those data? And all those government institutions, I think it is possible to integrate using the API. All those personal details that it is in NIRA, so that if I went to the bank to withdraw my money, I don't necessarily have to go with a physical ID, because my face is already there. My photos are there, so you can easily verify my face from the bank, and then you'll be able to give me the money when I want maybe payment regarding my health and all that. But if you look at the government system we have right now, it's still predominantly paperwork. And yet, if here already has our national ID, even if you have lost it, we should be able to access the services, like financial services from the bank. Thank you.
I thought someone would suggest that we get IDs that don't expire. The last question. Finish.
The question I was already asked 3 times, but let me summarize it in one word. Thank you, Madam. You presented in your presentation, you asked a question, where are we at? And I would like to pose that question back to you. Where is NITA at in terms of how it is prepared to resolve emerging issues that have already been enlisted by the consultant and Professor Kiria in terms of data sharing and data integration? This I picked from the digital landscape in Uganda that you presented. Thank you.
Yes, questions are over. Over to you, Madam Julia.
Maybe, okay, no, I think it's getting the feedback.
Very interesting questions, and it's good. It shows that one, people are paying attention. Then two, that it's very interesting for government to be engaging or to be working with most of you on moving this agenda together. So for me, this is good feedback, and definitely we'll take it on and we see how to make government better in what we do. I'm going to start with Rose. Smart education and intelligence, what we are doing around that sector or that area. When you start talking about smart, the first things that we always, by default in technology world, infrastructure. How many of our education schools have connectivity, have internet? We have instances where our very interesting development partners go to the schools and give them computers. When we move around as an authority to assess, we find some of these computers still in boxes. Why? Because they do not have the infrastructure is not in place. So what are we doing around that? One, of course, by default, the first thing that we're trying to ensure is that all schools are connected to the fiber so that they can access internet. That is one. Two, we are looking at partnering with a number of people for access to devices. You can't talk about smart education unless somebody has where to access it from. How can we avail tablets or computers to these schools? So one is connectivity, two is access to devices. Now the third one, which is now the smart part of it that comes into play. We've been working with UNICEF on a program called Colibri, where we are looking at e-learning as one area. We want to see how can we provide our ordinary schools, not the schools in the urban centers, our ordinary schools, information and data and content education data on these machines that we are providing them. We haven't gone far because we are still grappling with infrastructure. Okay, the private schools are doing well, but even the private schools, there's a bit of change management. Most of them are not yet there, but at least there's some digitization around that. So as government, we want to ensure that we provide the infrastructure first, and then the devices, and then we'll go to the automation to make it a smart education. Again, also in that sector, we have a lot of silos in there. There are many government systems in there, but again, that is our problem that we need to solve. Dissemination, I think I go to our colleague, I missed your name, Sir. I take note, and maybe also to the consultant about the interoperability framework that is not on the website. I need to ensure that that one is sorted out as soon as possible, because one, it exists, it's there. We rightly said we have not done a very good job in terms of dissemination. We are in the process of updating it to accommodate the emerging technologies, because we did that about 2017, the National Interoperability Framework and Enterprise Architecture. We are in the process of upgrading it so that we incorporate all that, but mindful, I will ensure that dissemination is very key once that is done. But still, we can still engage and ensure that we work with you on the same. Interoperability has been a very key question in almost every person's point that we made. I don't know how to start with it. Yesterday, I think I had one of the presenters talking about people, technology, and another third one that provides the entire ecosystem of digitization and technology usually is not the problem. The problem is usually the people. Specifically in the health sector. As government, as NITA, what have we been doing to ensure this interoperability and data is being done. One, we have provided what we call, which I talked about, the data integration platform. What that platform does is provides technology to allow anybody with different API or different API technology that they have to be able to exchange data. It helps you to change. I don't want to get into the technical details in there. Now, we started with the health sector and we said, okay, you have 64. And maybe before I get to what we are doing, one of the biggest challenges we have is the development partners. Development partners come, they sometimes even do not go to the main ministry. They go to the district. They go to one of the health centers at the district. Tell them, we have this nice system. We're going to give you computers. We're going to give you everything. What do you need? No, we just need a room and we need people to enter data. And of course, knowing our ordinary people, it's a project, right? It will come with allowances, it comes with all the many things. And they will set up a system. Before you know it, you have a health center running a system. And then later on, they now start going upwards, telling the Ministry of Education, of Health, there's a system there, people here, and so on. We agree and acknowledge as government, we also have a challenge around coordination. That one we agree and we know. So in regards to data being shared, how do we manage that? It's a big problem because some of these, our people accept, even when they know that the system already exists somewhere else, because World Bank or because UNDP has come from different channels. They come under Malaria Consortium. See, now we know project under that, they bring a system, they da-da-da. Then another place, HIV, and so on and so forth. At the end of the day, interestingly, that data is not even in Uganda. What are we doing around that area? So one, we've put up this integration platform for those that the Ministry of Education has said that now these are moving forward going to be our core health system. And you've seen, we've talked about the medical, electronic medical system, the DHI. Now, what Ministry of Health has done with NITA's support, again, for us as NITA, we are more on the support side, from the technology side and standards and so on. But we need to work with these agencies and ministries to ensure this happens. So what the ministry is doing is that it's trying to shut down, which is not an easy thing, trying to shut down most of which are almost the same or doing the same things, and we have one or two or three standard systems across the board. I don't want to get into the administrative part of it because it's a challenge shutting down most of those systems. They have many factors behind them. But we are trying. It's not easy, but we are trying. The second thing is that when we try to integrate some of them, the technologies that they used, I want to give an example of, I forgot which particular one, the API technology that they had, people had REST, others had FHIR. There's a new FHIR integration framework that most people are using. Some people have different. And we tried and they said, no, for us, this is what we use and so on. But from technology perspective, it's easy. It's easy to work with technology. The problem is people. It's people and the other bit. Just to answer you in summary, is that it's a journey. I cannot tell you that we are going to solve it tomorrow. But what we have done with the Ministry of Health is that we have decided to identify 1, 2, 3 systems that are going to be used across the board in government. All these other small ones shut down. Then lastly, we have aggressively started engaging the development partners. Because the development partners, the first few meetings we had with them, they said, but we did not know that some of these systems exist. The people did not tell us. So we also brought them. So we want to engage them so that before they implement, before, all the stakeholders are involved in there. Infrastructure sharing. I want to tell you that Mulago talking to Tawika is not usually a problem. Again, it's the people. We as NITA, we are trying to enforce what we are calling it an N7 process, but it's a process where if any government institution is supposed to procure any system, they have to come through NITA for approval. Now, in that process, we try to ensure that we don't allow certain systems to be implemented because some of them do exist. Now, you'll find that the system in Mulago is owned by somebody else, and the system in Butavika is owned by somebody else. In other words, the vendors. So the challenge is not technology. We do have the brains in the country, most of you here. The problem is administration. So convincing Ministry of Health that moving forward, all referral hospitals should have one system, one centralized system. And that is what we're trying to do across the board. So in future, in regards to ensuring that they speak to each other, that will be easy. It's a journey, but we've started. We've started on the same. Albert, in regards to cybersecurity standards, we have the national cybersecurity framework. I don't know if you have come across it. Again, I hope it is not missing on the website. We have the framework on the website that we use for standardization of cybersecurity. So you need to go and find out from there. If not, please get in touch with me before I leave to ensure that you have some of those standards provided. Mpato, I hope I've pronounced it well. Interoperability framework, again, is the same issue. Dissemination is a problem, and we're going to work on it. Can the health system be able to speak to each other? Yes, they can. The challenge is not the technology. The challenge is administration, which we're trying to manage. It comes back to, I think, in one of the speakers mentioned top management support, high-level management support. That is where we need to work. Down here, connectivity is there. We've connected all the files. Why wouldn't they talk to each other? But we need to manage that layer up there. Top management, once they are with us, and it is our mandate to ensure that is going to happen, or at least we're working on it. National ID. Yesterday I was in a steering committee for the national ID rollout of the new national ID. About 15 million people's national ID cards have expired. So yes, Professor, your card has expired. We sent out communication. We, that is government, not NITA. We as government sent out communication. We're supposed to have renewed all these cards a few months ago. However, the system, the new system, which is replacing the old system, was not yet ready. So as government, we said, yes, you have expired cards, however, you should not be denied services. And we ensured we sent that communication to all sectors. Okay? Now, I need to see you afterwards. However, because everybody's cards, about 15 million Ugandans' cards have expired. So it would mean 15 million people cannot access what? Banking services. Yes. Yes. It's expired. Yeah. Look, definitely. What the banks, which I think I mentioned earlier, under the integration platform that I did, most of the banks have integrated with NIRA database for KYC and all that we need to do. Not all of them. The other day I went to one of the banks and there were still papers. I'm like, what do you mean papers? You mean like their system was not yet integrated with NIRA, but that's a different matter. They are expected to allow now. I didn't want to get into the details. On 27th of this month, all of you are going to be allowed to renew your national IDs. It will be online, but of course there will be some, you will still have to go to get biometrics, but we're trying to put the services online. Currently that is not possible. But after 27th of this month, we are going to send out communication. You're all going to renew your what? National IDs. And you'll be able to get them after 2 weeks, maximum 3 weeks. Have not, I don't know if they've put an expiry. There's still internal discussion on whether national IDs should expire or not. That's still internal. I'm not in position to comment on it, okay? What I want to say, as far as national IDs are concerned, you're going to renew your national IDs moving forward. However, we expected all institutions not to deny you services. That is why I need to raise this, because it's very important. Because if you notice that they were relying on the new IDs for Electoral Commission registration process, but they decided to proceed with it without the new IDs. Nevertheless, we should be able to. So just following up on the same, Nelson asked why is the national ID not integrated? National ID is actually platform integratable and ready for any of innovators or people, private sector as well, to access that national data. You just write to NITA and then, you should be able to do that. Some banks have done it, others have not. So I would be a little surprised. They've moved away. That's why nowadays getting an account, bank account is online. It's as easy as, you don't need to go there because they're already integrated on the same. Mwilo, I think, was talking about the silos and coordinated systems. What is NITA doing? We have to work with the agencies. We have to work with the Ministry of Health to do that. From the technology perspective, it is possible. We have the infrastructure. It is the goodwill that we need to get from the top management of Ministry of Health and most of this to allow that to happen. So the issue is really not on the technologies. The issue is with the senior management of the different institutions. Lastly, where is NITA at in terms of data sharing? At least in terms of the enabling environment, we provided the data protection that allows us to be able to do that. In case you're not aware, we also have the national data bank regulations that allow seamless sharing of data. So in terms of regulations, we do have. So once the regulations are done, what next? We are providing a platform within government, but also exposing it to the private sector for you to access government data. Again, I think the problem that we have, which I've noted and I'm going to take back, is dissemination of information, which we'll do, but that is possible and that is where NITA is going. I have tried to summarize most of them because some of them were almost similar. I want to hand over back to you, Florence, unless maybe somebody have not answered properly and need some more clarity.
The good thing you have assured us, we can see you.
Yes.
Or it's only from we can see you.
Everybody can.
I wanted to ask something. Does it mean now we are expired Ugandans?
ID expires?
No, you're not expired Ugandans.
Okay, that's all. That's all I wanted
Yes.
to clarify.
And
Because
maybe to
my ID where I come from, I got it when I was 18 and no renewing. So I was wondering.
Just to add Florence on the same, this is more of awareness. The new IDs are going to be digital IDs, right? So it comes with extra features.
At least clap for that one. Do you know that is there?
So the new IDs are going to have extra features, extra security features, and they'll be digital. So hopefully in future, when we're going through Entebbe, we'll have digital, sliding of our passports and national IDs.
And
right?
will not fail to get one. That's all. Thank you so much, Madam Diana. It has been a task, yes, going through those questions and standing in very, very calmly. I really thank you for that. And at this session, as we invite Madam Juliana to go back, we shall have seats arranged back because we are going to have a panel. But we need to have a group photo. That's what I'm being, but the cameraman is doing like this for digitalization. So, in government, we have to have evidence.
Before you leave here, you better give me a solution. Because this is serious, it's a meeting.
Then Dr. Hilda is going to take over for the panel. Thank you. Have a blessed day.
If you want KYC,
Oh, I've been told that the group photo was taken yesterday. Madam Juliana, I've been told that it is you. They want your photo because of the answers you've given, for the evidence that you are the one that gave those. Okay. So, you know those days when it was not digital? The film used to get finished when we have posed for the photo. Did you come from such big? We wait for the photo, then they say the film is finished. I hope. I want to invite Prof. Rose to hand over.
Next slide. I put up this slide just to give you, a bit of a snapshot of what we're doing as government. Digitization. Next slide. I put up this slide just to give you, innovators in this room. If you want KYC, our insurance companies in this audience, if they are there. If you need to access the national ID, which is innovators in this room. If you want KYC, our insurance companies in this audience.
So next we shall have the panel discussion, which is going to be moderated by Dr. Hilda. Over to you.
Thank you very much, Florence. Thank you, Madam Julian Nitayu. I think you have made a very good representation of Nitayu, but one thing I've noted is that the systems are in place, the frameworks are in place, but the problem is the enforcement. And the key word that I noted was people and administration. So I think that is going to be worked upon. At this moment, I want to invite the panelists for the next
Next
session.
slide.
And we are going
I
to
put up
also
this slide
discuss
just
a very
to give you,
interesting,
a bit of snapshot
interesting
of what we're doing as a
topic
government.
here. I'll invite Dr. Jerome.
Next slide. I put up this slide just to give you, a bit of snapshot of what we're doing as a government.
Dr. Jerome is a pharmacist and a lawyer. He is a health and medical law specialist. Welcome, Dr. Jerome. Please take your seat. We shall also be having Dr. Gracia Kalule. We shall also clap for Dr. Kalule. Dr. Kalule. Okay. If Dr. Kalule is not yet here, we shall be joined by Councillor Jordan Magala. Councillor Jordan Magala, you're very welcome. Please clap for him. He represents Minister of ICT. Thank you. I've been informed that Dr. Kalule is online, so we shall be putting him through. Councillor Jordan Magala is the personal data protection, works in the personal data protection department and represents Ministry of ICT. You're welcome. We shall also be joined by Dr. Kresh Milo. You're welcome. Please join us. As he comes, we clap for him. And Dr. Milo is a pharmacist and a health technology researcher and a lead in research and data at Mobi Clinic. So that is our panel. At the turn, when we have a question for Dr. Kalule, we shall put him through online, and we shall now let the conversation begin. I have a team here, and we are going to discuss, we have had a lot during this Vitendo digital health discussion. We want to act, but as we act, we are interested in not going against the law, and that is what our discussion is going to be about this morning. We were going to learn a lot from these panelists. Question number one, we shall direct it to Dr. Magala Jerome. Dr. Magala, we want to hear from you what ethical considerations must be kept in mind when collecting, storing, and using patient data in Africa. Also, what are the biggest legal blind spots? What are the biggest legal blind spots when it comes to digital health data protection in African context? Thank you very much.
Thank you, Hilda. Once again, there was a misnomer there. My name is Mpata Oakage. I am a pharmacist, a practicing pharmacist, an advocate. For present purposes, I do some work as a consultant supporting 2 or 3 organizations. That's the Pan-African Health Informatics Association, as well as Transform Health, working in collaboration with the Africa CDC and the African Union. And the idea is to draft a model law for health data governance, firstly on the continent, but also globally. And again, this will be part of the discussion at the World Health Assembly that's happening starting 19th. So into the substance of what ethical considerations we should have, already the field of ethics is very linear. It has about 4 principles, as many of you may know better than I. But for me, I would like to start with autonomy. And under autonomy, consent. Consent is a very pertinent consideration when you're speaking about digital health and regulating or legislating for digital health. So there are about 3 or so observations one makes as you interact with digital health regulation on the continent. First is consent in many African settings. In many hospitals, Uganda inclusive, is omnibus, it's not purposeful. So what happens is it is even assumed that the moment you enter a government or public facility, you've consented to everything that's going to happen to you while you are there. So rarely do you see patients, especially in lower socioeconomic settings, but even in private hospitals, because I have had the misfortune of attending a private health facility in Uganda in the very near past. And I was sent to do my blood, and I was just told, roll up your sleeve. There was a tourniquet placed on my arm, and then blood was drawn. I wasn't given any information of what is the purpose of the blood, how much blood do you want, what happens to the leftover samples, etc. So that's a very typical clinical interaction in Uganda, and I think it takes away patient autonomy. But also going even more Afrocentric, consent means different things for different communities, and this is a challenge of copy and paste and lazy legislation for many African parliaments. You realize that of the, I think 32 at the last count, 32 countries on the continent of the 55 have some form of data protection regulation. But about 30 of those are copy and paste of the European Union General Data Protection Regulation, not much difference, not much innovation. But in practice, consent means different things. At least this is what I have learned over the course of the work that I am doing. You will find, for instance, in some communities, that if a husband or a wife shows up with a husband for healthcare, it's not consent if the husband has not consented, even if the wife is the patient. And this is their reality. You can take a Eurocentric view, but it won't disturb that reality. So that's what consent looks like for them. So whereas, Europe tells us the patient must consent, in this society, the husband must also consent. And you'll ask the patient a question and she won't answer until the husband obliges her to answer. So we need to take a very Afrocentric lens to the meaning of some of these things that we are copying in our legislations. I think very much our own constitution takes a Eurocentric view, as well as the DPPA. So that's that. Now, the other is how do we achieve autonomy in low-income settings? Again, when you look at the typical public healthcare interaction, you have an overworked provider, a nurse, or a clinical officer that has over 1,800, whatever number you pick, should be overwhelmed. And then you have this patient, like me, for example, who has some knowledge of my rights. So imagine that interaction. You go to Health Center 3 in rural Uganda. You're called into the clinical room, and then you start asking the nurse practitioner or the clinical officer, why do I need to do this test? Exactly why am I being asked this question? So you're likely to be seen as a very problematic patient, and you're likely to be pushed aside because there's already a long line waiting outside. You're likely to be pushed aside in favor of more compliant patients that will, have no option but to waive their rights. So the next ethical principle, and I am but the next I would look at is beneficence and non-maleficence. The idea that interventions have to be beneficial to the people that are giving the data, and that they should do no harm. Again, we have been taught by so many scenarios in global health that although we generate a lot of data on the continent, we are not the beneficiaries of this data. I think the previous speaker, Madam Juliana, also mentioned that the plan for Africa is that a lot of our data is not even stored on the continent. And this is the reality. And I experienced this in Malawi when the Ministry of Health, and I suspect this is the case in Uganda as well, the Ministry of Health was not the custodian or owner of their HIV-related data. So in order for them to access data concerning prevalence, concerning infection rates for HIV, they had to write to a USAID project, and the data was somewhere on a server in Baltimore. So an African government generating lots of data does not own the data. It is stored elsewhere. So again, this shows the power imbalance of the politics in global health. It's well said that data is a new gold, and one might even stretch it and say that health data specifically is going to be changing governments in the near future, because again, the health of our leaders seems to be the best kept secret. If somebody knows that our current president is sick, that is a secret that's worth, so much. In Cameroon, presently, they're dealing with a situation where the head of state has been out of the country for several months. He's sick, but you can't even talk about it in the newspapers. So how much more power would you have if you have that sort of information? Or if the United States has that sort of information? Or a certain power in the West has that sort of information? So in the interest of time, there's plenty I could say about ethical considerations, but I think when you go through the 4 principle ethical model and look at autonomy, and look at beneficence, and look at non-malfeasance, and even look at justice, questions of equitable distribution of these resources, there's plenty we can say in the African context. So I'll just go to the legal black holes that you asked. Again, like I've indicated, one of the legal black holes is legislative laziness. We are copying and pasting laws that we can't implement. In Uganda specifically, it's good that Madam Juliana is in the room. Even the institutions, the governance institutions we have, are undermined by the legislation. The PDPO that Madam Juliana spoke about, when you look at the Act, is subordinate to NITA-U. Now, NITA-U, under its Act, and I think again Madam Juliana highlighted this, NITA-U's main objective is to service government's ICT needs. Now, it is even made more complex in Uganda because about 70 or 80% of health services in this country are provided by the government. So we're talking about the government having access to about 80 to maybe 90% of health data, the 10% being in the private realm, because many of these big private hospitals are only in the urban centers. Now, if you're going to go to PDPO to allege a data breach, it is 90% likely that that breach was caused by the government. And you're reporting it to PDPO, which is under NITA-U. So I wonder what we expect the government to do to itself in the event of a massive data breach. And again, we've seen, and I don't want to get political, but we've seen some of our leaders on social media make very, very dangerous revelations. So I wonder where the incentive would be for NITA-U to rein in on a massive health data breach for someone, for example, like the guy that is currently incarcerated in Luzira. If his health data leaked, what is the incentive for PDPO and NITA-U to try and, intervene in that sort of situation? So that's one of the, I think the second or third blind spot. I'll just cede the floor because I could speak all day on this issue.
Thank you very much, Dr. Jerome Magara Owagage. Thank you for sharing with us your knowledge. You have talked something very interesting about consent, and I think I will stick to that. Your clinic innovators, I hope we have the consent section on your platform. If not, please take note. I'll go straight to Dr.
I'll go straight to Dr. Jordan. Dr. Jordan Akara, sorry, Council Jordan, I'm sorry. The question to you is, how is Ministry of Health and ICT responding to the challenge of regulating emerging technologies and supporting innovation? Over to you, Council.
Okay, thank you so much. Thank you. Again, for clarity, my name is Jordan Magala, and I work with the Personal Data Protection Office, which is under the Ministry of ICT, and I'm a legal professional. And to start with, maybe for those that haven't heard about the Personal Data Protection Office, which is the PDPO that has been referred to, which is Uganda's regulator when it comes to data protection and basically personal data. And you recognize that in our different health profession, we interact a lot with client data, personal data to be specific, and which is special personal data when it comes to the health data. And this, of course, requires a high degree of protection. And from yesterday's engagements, we had a number of speakers noting down that government has a tendency of stifling innovation through its regulation. But that may not necessarily be the case, because yes, we embrace innovations and technology. We appreciate the need for these emerging technologies. We can't live without them. And a recent study from Harvard University revealed that AI is here has the ability to increase workplace productivity by over 40%. And I think from what the Vice Chancellor mentioned from the insights of yesterday, that yes, what will kick out people will not be AI, but people's inability to use it to be able to advance productivity and efficiency, specifically here in the health sector. Now, a number of challenges come with regulating these emerging technologies. The first being the advent of data breaches. Because we do realize that a lot of this information is very sensitive, finding out someone's maybe results that have been done. I know that, for example, through this new product from Mobi Clinic, the Your Clinic application, a number of tests can be run on this application. Someone can be able to submit a lot of sensitive information through it. But then what happens in case of a breach? Is this something that has been envisioned and something that has been prepared for? So some of these challenges come with these innovations, and the other being the privacy, because this has also been talked about, that some of these actually have this information stored in countries outside Uganda. So when it comes to the cross-border transfers, are we actually looking at how and whether these countries, this data is being hosted, for example, have adequate measures to protect this kind of information? So these challenges come, and of course, even the other being awareness that many health professionals may not even be aware on the challenges that come with not protecting some of this information. But as the Personal Data Protection Office specifically, we've come up with a number of measures to be able to advance and embrace these innovations. The very first was being discussed again by my senior colleague, Julian, which talked about the National Health Strategy, which is expiring this year. And because of this strategy, last year, PDPO, together with the Ministry of Health and NITAU, we launched the Compendium on Digital Health Guidelines. I don't know if any of us here has interacted with these guidelines before, because they have a number of guidelines, for example, on data protection when it comes to digital health and confidentiality. They have guidelines to do with innovations to do with digital health. So all these are there, but then I don't know if we've taken the initiative to have a look at them as we go about these different innovations. And these are there again to, yes, embrace different emerging technologies that come with digital health, but also be in position to promote the privacy of the individuals. My colleague here, Jerome, talked about autonomy of the patients. them being able to give consent, informed consent, even as they use these different platforms that are being innovated. That is something that is very important. And recently, I think around 2022, there was a recent data breach, specifically on health data, that affected, it was from one touch point, which is a third party to most of the different healthcare providers, the digital healthcare providers in the US. And this affected over 2.6 billion people, where they had their different health data, their results, and the kind being exposed. And of course, there's a class lawsuit right now that's going on against them, but even a third-party element now that you may work with. Yesterday there was a question on if insurance is also being catered for within the Your Clinic application. And it was mentioned that yes, it's something that is going to be worked on and implemented in this application. So what are we doing when it comes to the third parties we bring on board? Because yes, as digital health providers, we may have all these measures in place to protect the data that we collect and process. But then the different third parties we also work with need to be in position to adhere to the same levels of protection that we have. Again, as the data protection organizations, because we understand that yes, data protection in a sense may be new in this landscape, but then how do we enable organizations adhere to the same? Because we don't want to just come and say, oh, you're in violation, pay this amount of money, pay this fine, but we want to first ensure we create that awareness, and through that we've been able to develop that compliance toolkit. And again, on the awareness bit, starting this financial year, we'll be rolling out an awareness campaign.
Next slide.
Nationwide,
I put up this slide just to give you, a bit of snapshot of what we're doing as government. You need to access the national ID, which is very innovators in this room. If you want KYC, our insurance companies in this audience, if they are there. If you need to access the national ID, which is very innovators in this room.
But also different organizations that are registered in PDPO and collect and interact a lot with the data to be in position to comply better with this particular law. Thank you.
Thank you, Council. Thank you very much. Hello. Thank you very much, Council. Thank you for your response to this question. It is interesting to know that we need to educate our people, including third parties, about data privacy, security, ethics. Those are the third parties, because we realize that the biggest challenge is the people as well, as we are trying to enforce the digital health guidelines and protection, confidentiality of our patients using the developed tools. We need to also ensure that this is emphasized. We are excited that there's also the compliance journey, developing the curricula for that, and we look forward to looking at what it will bring with it. Thank you very much for your discussion. We shall come to you, Dr. Milo. The question to you is, how can we build trust among communities? How can we build trust among communities and patients when it comes to digital data usage? Also, would you have any examples where digital trust was built or lost in your experience, and how was this handled? Over to you, Dr. Milo.
Thank you so much. Briefly introducing myself, I am Dr. Kresh Miro. I'm a pharmacist and a specialist digital health researcher. Been in that field for about 7 years. I did research and data at Mobile Clinic, but I've also sat on the WHO Civil Society Engagement Commission representing the digital health space. So to respond to your question, how we build trust in the communities about digital data, I think, in my opinion, it starts from sensitizing beneficiaries, why it's so important for us, for the providers, and for the regulators, or for any stakeholders in digital health to actually have access to their data, why it's important, especially in terms of service provision, but also sensitizing them about the rights that they do have about this very sensitive data. As we may all know, that having material knowledge of, let's say, infections that someone may have, elicits different emotions and consequences for those who may know and for the patient themselves. So using context-specific examples as for the greater good of their own well-being. Then, secondly, throughout the entire journey of rolling out digital tools, as a researcher, there is something that I've noted over time, that successful adoption of digital health tools starts from empathetic and inclusive development, working with beneficiaries in mind. So when you're bringing in change in a community, for instance, that wasn't previously digitized, you have to engage starting from local leadership structures, the laymen, the lay leaders in church, and other religious organizations who can actually influence the masses to adapt the new change that you're bringing on board. So this is the step we usually take, and we've seen that it has been highly successful. Once you have the inclusivity, once people know that you're designing something for them for their own good, and you enlist their opinions, their ideas, I think chances are high that you're going to have success with digital health and eventually associated data, and you won't have a lot of negative reactions to the change that you're bringing about in the communities. And then the third point that I may mention is transparency. As Senior Counsel has mentioned here, it's very important that patients have autonomy over the decisions that they are making. But for them to have autonomy, it has to be informed. You have to share with them all the necessary information about what you're going to do with the data you're collecting, who is processing this data. So it brings in about all the principles the 4 principles, the ethics principles that you mentioned. You mentioned that there is no harm associated with this data. Once you have all that done, then you're going to have good relationships and compliance, and also adoption of the different digital health systems that you will be developing. As the moderators asked me if there are any cases that I might have witnessed or heard of that have led where trust has been broken. Locally, these don't really make news, but I know this could be because people are not aware of their rights. Maybe over 90% of the people, and actually even those that are aware, probably can't enforce their rights. But in countries like the UK, as Kat has mentioned, in the US, there have been so many cases that have caused a lot of consequences for various providers and for governments. Point in case, in 2016, one of I think the biggest AI companies currently, DeepMind, which I think was bought by Google, had a massive data breach in the UK when it was working with the NHS, and I think it affected records of 1.6 million people. In spite of the fact that this company had strong, actually it wasn't even a data breach, it was unauthorized use of data to train many AI models. So in spite of the fact that they had the infrastructure in place to protect the data, to ensure that it can't leak, still they were liable because how they used the data, they used it without informing the people where this data was collected from, and this has been a precedent that has shaped henceforth how data is dealt with in digital health systems. But then also locally, in my own experience working in the rural communities of Uganda, cases where I think we lost the trust, but maybe rebuilt it after some time. So as you may see, Mobile Clinic is Mobile Clinic. So when you try to maybe have a short form of it, chances are high that you're going to have MK. So there is a time we rolled out biometrics technology to the communities where we operate, and it was facial biometrics. Basically, someone scans your face and you attach health records to that. So the first time we were piloting biometrics technology in the communities, as our project was progressing well, the ID of every beneficiary had something, MK000 something. So later on, MK became a much more popular phenomenon, but associated with a whole other movement. So we faced consequences that we are in the community, we are offering services, really doing good, but then you find questions that, hey, this is MK, I think you're using my data for this and this. I think this is related to politics, this is this and this. So when we did an evaluation of what we were doing in the communities, we found that 10% of the beneficiaries actually weren't willing to have their biometrics taken. And the reason they were giving was that this is MK and this is politics, you're getting my photos and you're putting them in registers, you're doing what? There was a lot of conspiracies, but then when we explained this, and then I think with the structures we had set up initially, that we're working with local leaders, laymen, it was easier for us to overcome this challenge that had come up, and eventually we had successful delivery of services using digital home technology. Yeah, that is my submission. Thank you very much.
Thank you very much, Dr. Mido. I'll start with the interesting, I'll call it interesting, because if your clinic was MK clinic, maybe it would also have brought some other parties, I'm not political, so I'll not complete the sentence. Anyways, so for the acronyms that you're using while designing our digital health systems, we want to also encourage the developers that please avoid anything political that may be misinterpreted by the recipients. Thank you very much, Dr. Mido. And maybe also what I picked from your discussion is that as we are building or as we are thinking of the various innovations around digital health, we are looking at sensitization benefits, also building context, and also creating transparency. But how do we do this digitally? Are we going to have a platform where we're going to explain to the users or try to build trust, whereby maybe you're speaking through and trying to give affirmation to the users that this system is very secure and your data is very secure, and also giving them that bit of assurance that even if I'm interacting with the system online, at least I have an assurance. The consent, we have already talked about it. Now we are looking at the issue of trust. How do we build trust digitally? Thank you very much, Dr. Milo, for your contribution. I'll get back to you, Dr. Jerome, with another question. Are existing data protection laws sufficient to govern digital health solutions across Africa? We want to hear your opinions on this. Thank you very much.
Hilda? Well, the short answer is no, and this is not just because I am a pessimist by nature, but the short answer is no. I'll just go into a few of the reasons why I think they aren't. Number one, I don't think they adequately deal with the issue of privacy. And there's so much to speak about privacy alone. But I'll give you several instances, or at least one in Uganda, and what I experience on a daily, and perhaps Croatia as well, because we are in some similar WhatsApp groups, or at least social media circles. There is a tendency now amongst healthcare professionals, perhaps it's well-intentioned, but to share patient information via WhatsApp and in very large groups. Even today, I think there is one or two that we share either prescription or photographs, very intimate photographs of the patient, and ask colleagues, what do you think? What could be the differentials of diagnosis here? What medication should I apply? What would you advise? What's the last item? I can't quite read this prescription well. And this is happening, and it's obviously unregulated. But again, it breaches patient privacy, because a lot of times not much effort is put into concealing information that pertains to the patient. But that said, even our own laws that ordinarily would clamp in on such behavior, aside from the professional misconduct realm, you will find that they were not designed for health specifically. They were designed for data broadly. And so, like my colleague Magala will tell you, there is only, health data is only a footnote in the big data protection conversation. You will notice that I mentioned that 32 countries out of the 55 in Africa have some form of legislation. But that legislation is for data protection, not for health, data protection. So we are already inadequate in as far as data protection is concerned. We are acutely, severely inadequate in as far as health data protection is concerned. When you read the Data Protection and Privacy Act, it will define personal information as information that pertains race, marriage, somewhere mentioned health related. Now, again, I think
for not complying with the DPPA, because that's a legal requirement. If you have companies the size of Rocket Health, I suspect Mobile Clinic is not yet compliant as well, but Bureau will advise us. But if you have such companies that are collecting so much data, I think Rocket Health was a hub of data during the COVID pandemic. But the last I checked, and this was, I think, at an APAC conference in 2020, there is already a project. This is an entity that has millions and millions of data sets pertaining to many countries. So I think the enforcement, rather than ask the question of how many have complied, we need to ask the question, how many are being made examples of for non-compliance? That should motivate the others to similarly comply. I've already spoken about the lack of regional interoperability. And then also the unregulated health app space. Now this is a very important conversation to have, especially since Mobile Clinic has just launched your clinic. My question would be, who is the regulator? What steps did you have to go through in order to launch this app? Are you, governed or regulated by anyone? But my experience really is different. On this phone, I have about 4 health apps, and I'm very minimalistic. I know people out there that might have, 10, 11. You have an app for a pedometer, the number of steps you take in a day. Some of you have apps that measure your heart rate. Some of you have apps that measure your pulse. I installed apps on my mother's phone that tell me her blood pressure, blood sugar in real time. Now, the only thing I don't know is where I'm sending this data to. I don't know whether the server is in Cyprus. I don't know whether it's in Kololo. I don't know whether it's in Greece or it's in the United States. But even if that's worrying, I don't think NITAU knows either. I don't think PDPO knows. Now, these are apps that are in everyday living for many Ugandans, actually for most Ugandans. So we have all this health data. We have no idea where it is. We have no idea what the collectors use it for. And I'm not excusing myself. I also consume these applications. So we have a very unregulated health space. So I wouldn't be surprised if your clinic, as an application, did not have to undergo any regulatory approvals or steps.
I was waiting till he's done, but I think I have to pass this disclaimer.
I wouldn't be surprised. Surprise me.
So, Mobile Clinic is compliant to the PDPA and also to the NITAU Act.
And your clinic as well.
Yes, Mobile Clinic as an organization is compliant and all our digital products. Today we are launching your clinic, but we have many more other products that are all compliant to the PDPA and NITAU Act.
Okay, so thank you. So I'll just make that last point, if you will, Hilda. It's on the right to privacy. And again, like I mentioned, and I think Professor mentioned yesterday, we have it on the books. But again, there's the Afrocentric element on what privacy really means for many Ugandans and what it doesn't mean. Especially when you go to reproductive health, you will find that the interpretation of the right to privacy can also be very fluid. I know that there are many in the African family setting. You'll find that whether or not a mother can give birth may not be as private as you may want to think, because in-laws may want that information. There are certain social decisions that are based out of that information. So I'm not saying it's the right thing to do. I'm saying every time we copy and paste these laws, we need to infect them with some local flavor for them to make sense to us all.
I would just request for a few minutes to make some comments on some of the things that arose from Jerome's.
Please go on.
Okay, thank you. Very first was on this data that we transfer outside Uganda, these servers that we use for the cloud services, and whether PDPO and NITAU are aware of some of these things happening. Now, just to remind you that at the point of registration with PDPO, among the sections that are required to be filled is on transfer of data outside Uganda. And we've had a number of organizations transfer this data outside Uganda and inform us of where these countries actually are. And again, they're also required to fill the Form 3, which is an undertaking to transfer personal data outside Uganda, unless the other country has adequate measures.
Specifically, one will even stretch and the institutions, the government institutions we have, undermine parents, the health of our leaders, CDPO, if somebody knows that our current plan is subordinate, specifically, in Cameroon,
before you transfer data outside Uganda, if you want to have cloud services being housed by Google, have you had a transfer impact assessment done on the country where these services are going to be held? And of course, again, it's always good to seek approval from PDPO or a review from PDPO to get an insight and seek that clarity on some of these. I know that yes, as an office, we're supposed to come up with a list of countries that have these measures in place, but that is still a work in progress. And then the other being on independence of PDPO and VIDIHSA. Again, this is an interesting scenario because according to the Act, it provides for that independence, and we've taken deliberate steps to create that independence because, for example, the ED for PDPO does not report to the board of NITA. Does not report to the ED for NITA.
one will even stretch and say that the institutions, the government institutions we have, underlying by parents, the health of our leaders, somebody knows that our current president is subordinate and is secret. So much in Cameroon, the situation even the institutions, the government institutions we have, underlying by legislation. VDPO, one will even stretch and say that subordinate specifically is going to change the specifically.
Because this is an annual requirement that is supposed to be done annually, and I think the last time I checked, expired in March, the 28th, but yes, there is need for having that.
I also want to add a disclaimer to that. We are in active process of renewal since April this year. So that actually the process started earlier, but I don't know why, even in the process of actually getting our first licenses, both from NITAU and PDPO, there were certain delays that we couldn't understand why it would take long after all reviews are done, but certainly we got used to this is how government processes work, but potentially the government processes should work better than they currently do to ensure that these processes happen very fast.
Just if I could add, in the event that it is not yet renewed, so what is the status currently?
Currently, we check our status with PDPO. There is an online link that you can always check. So it shows we are compliant, but we know that it is expired as a matter of fact, and you've been in active process. I think the gentleman is called Isaac, who is currently handling our renewal. So, with our partners, especially who are not here, those